Greetings and welcome to the Cancer Interview Podcast. I'm your host, Bruce Morton. Usually on Cancer Interviews, we feature the story of somebody sharing the details of their cancer journey. But on this segment, we're going to switch things up a little bit and have as our guest a healthcare professional who's going to share information aimed at heightening your chance of avoiding a colon cancer journey. He is Dr. Whitney F. Jones of Louisville, Kentucky, and he's the founder of the Colon Cancer Prevention Project, which is also based in Louisville. Now, in sports, sometimes people will say that defense wins championships, but Dr. Jones is going to show us how offense can beat cancer. So let's get to it. And Dr. Jones, welcome to Cancer Interviews.
Bruce, thanks so much for having me. It's a pleasure. Glad to be part of the team.
Well, all of our interviews are a little bit different, Doctor, but we all start from the same place, and that is to get to learn a little something about our guests. So if you would, please share with us just where you're from, a little bit about your life's work, and what you like to do in your leisure time, when you have leisure time.
Well, thank you. I'm a native of Louisville, Kentucky, via Oklahoma, via Dallas, Texas, via Toronto, and via Tokyo. I finally wound up back in Louisville as a professor at the University of Louisville. My focus area was, in fact, advanced endoscopy, where I took care of people with pancreatic disease, bile duct problems, fancy endoscopy, microsurgery, as well as cancer. And what I noticed about 17 years ago, I guess, I saw 3 people in 1 week that had their bile ducts blocked by cancer that it spread from their colon and was obstructing their liver. So I got called in. I was never really a colorectal specialist outside of some specific procedures, and colon cancer was never part of my portfolio, if you will. But at that time, I just had my first child. And after that week of seeing 3 people who should have been screened, who had insurance, who were really smart, nice folks, who were probably going to die from this, I decided to do some research. And it turned out that Kentucky was 49th in the nation in terms of our screening effectiveness. And we were number 1 in incidence and number 1 in mortality for colorectal cancer. So, and those things are really linked, right? Low screening leads to high cancer rates. So at that time, I decided to conquer the world and start a nonprofit organization. I thought it would take me 1 or 2 years to get the word out and change issues. And so here we are 17 years later. And in terms of my personal issue, I'm an outdoors person. I love to be out on the farm. We love tennis is my favorite thing. I played collegiate tennis at the University of Oklahoma. And I've got 2 great kids, 15 and 17, a lovely partner who's in healthcare. And we just have a great time doing what our visions are. And, the work that we've been able to get into in the state of Kentucky has really been rewarding personally and professionally.
Well, it sounds like when UL plays UK in basketball, you're not a Wildcat fan.
Well, in the old days, we had a lot of really tension between UK and U of L because they would never play each other. UK wouldn't play any of the other state schools. So when they finally met in the NCAA back at 1980, it sort of broke that. And now we have a really great tradition in Kentucky where it's really a great rivalry rather than an unspoken, one school here, one school here.
Now, before we go any farther, we want to remind you, if you like what you hear on this segment, we invite you to subscribe to our podcast by clicking on the links below. Once there, you will see a bell icon, and if you click on that, we will notify you when we post a new interview. Now, Dr. Jones, on Cancer Interviews, we have learned that while screening opportunities for some types of cancer can be relatively easy, for other types not so much, and it sounds like what you're saying is that these days and in past times and in present times, hopefully not so much in future times, it's not so easy to get a colon cancer screening.
Well, I would say this. A decade ago, colon cancer screening really meant get a colonoscopy. Now we have a lot of options that are much easier for people who are asymptomatic and have normal risk. In other words, no family history, no personal history of inflammatory bowel disease. And so really, colon cancer screening has never been easier than it is in 2020. But that was not the case back in the early 2000s. And it really wasn't until 2000 that Medicare covered colon cancer screening as an option. So this really wasn't known until the 90s when an amazing man named Sid Winnower took a group of physicians and really set up what's called the Polyp study, where we proved that small polyps turn into large polyps turn into early cancers, and early cancers turn into late cancers. So there's this great opportunity to intervene in the precancerous state by identifying folks with these polyps. The issue is when you have polyps and you have early cancers in the colon or the rectum, a person has no symptoms whatsoever.
Now, if screenings are more plentiful than they were, that's one half of the equation. But the other half is the people need to get in to have those screenings done. This is a rather large demographic, but for people between age 20 and age 54, how urgent is it for them to get a screening?
Well, the national guidelines, according to a society called the USPSTF, United States Preventive Task Force Service, starts colon cancer for normal risk people at 50 and ends at about 75. The American Cancer Society came out with guidelines related to increases in early age onset colon cancer that were pretty dramatic to start that screening at age 45. And several societies had wanted African Americans to begin screening at age 45. So your risk between 20 and 54, first of all, I'd say if you're 45 and above, that's a no-brainer. You should have already been screened. Certainly if you're in Kentucky or other states that adopt 45. But your risk between 20 and 45 depends a lot upon your family history. Do you have a family history of large polyps? Do you have a family history of colon cancer, particularly in a first degree or multiple first degree relatives or multiple second degree relatives? The second piece, and this is important for your viewers, screening really is about people who have no symptoms but have some degree of risk, either high risk or normal risk, but no symptoms. People with symptoms of what may be colorectal cancer, such as change in bowel habits, rectal bleeding, unexplained abdominal pain, weight loss, unexplained anemia, that is not screening. Those people need a diagnostic evaluation by a healthcare professional to determine whether or not colon cancer needs to be excluded with an appropriate examination.
Now, you mentioned one thing that I want to touch on, and that is this notion of family history. I suppose it varies from family to family, but how can one have a better handle on what their family history is so that can give them cogent guidance in terms of going forward with their own screening?
That's a great question, and I hate to admit it, but it's one of the big uglies of colorectal cancer prevention. What used to be the most simple thing, and quite frankly, 50 years ago, it was the only thing that we knew were what ran in people's families. And so people who have a family history of colorectal cancer, particularly under the age 60, but now we're really talking any history, people whose first degree relatives, and that would mean your parents, your brothers or sisters, or your children in some cases, who've had large polyps or who have had cancer, really should be screened at age 40 or 10 years earlier than the diagnosis in their first degree relative. Likewise, second degree relatives with multiple cases should be consideration. So how do you know? Well, you have a talk with your family. I mean, November is Cancer Family History Month. So it's a great time at Thanksgiving to talk about it. And so often cancers have been sort of an area of shame for families. They didn't want to talk about it. Cancer used to be a death sentence, right? Why look for something that once you found it, you were going to die from it? But that is not the new paradigm that we live in, where, and in the colorectal cancer world, as well as we were talking previously about lung cancer and other things, there is that detection to find cancer early and save lives with that method. But in some areas, there's actually the opportunity to prevent it. So the single most important thing you can do is understand how cancer runs through your family. And it's not just colorectal cancers that may increase your colon cancer, but it may be endometrial cancers or uterine cancers. Ovarian cancers have certain genetic syndromes that overlap. Many of the breast cancer syndromes have overlaps with colorectal. So I think if there are things to think about, if you have multiple cancers in your family, if you have cancers at early ages, or if you have rare cancers, those are all red flags that you need to talk to your healthcare professional. And there's also many programs now where you can go in online and put in your family history, and it can spit out to you what your risks are, particularly for needing earlier examinations or even genetic testing.
Now, how would you go about doing that in terms of finding that out remotely?
Well, I can provide you the links, but there's several, I would call top tier companies that do genetic testing. Myriad Genetics, Ambry Genetics, Invitae Genetics, all have online tools or systems where you can, and essentially it just walks you through your family. Tell me about your mother. Did she have any cancer? What was it? How old was she when she had it? Certain other issues. So it's sort of like a Freesia tablet, which are the tablets that are in a lot of physicians' office, where it just asks you one question at a time and moves you through the algorithm. And I consult with Myriad Genetics, and so for full disclosure out there, but I think any of the evidence-based panels that are well out there and that saying are appropriate, and that people should really, know that genetic testing is available if cancer runs strongly in your family. And, let's take Lynch syndrome, for example. It's the most common colorectal cancer genetic syndrome in America. The gene affects 1 out of 279 people, but we only identify 1 person out of 10 with Lynch syndrome before they have a cancer diagnosis. And I think that's like landing the plane 1 out of 10 times, not acceptable.
Now, Doctor, you mentioned the genetic testing piece. Another element in terms of going on offense against cancer is a program of which you are a proponent called Leadtime Messaging. 2-part question. Number 1, how does that work?
Well, let's think about how you and I ended up on this YouTube interview today. You certainly didn't call me up at 10 o'clock Eastern, 8 o'clock Mountain Time and have this happen, correct? We had to meet each other, understand where we were, plan this in advance, and so that we have an on-time taping this morning. That took lead time messaging. And really, with regards to colorectal cancer and any behavior, we know that many times people need multiple messages before they perform a task. In marketing, it's how important the message is as to how many times you have to hear it. But in general, in marketing, they talk about the rule of 7s. But just remember the hurricane that happened in the Gulf Coast about a couple of years ago, where they down in Mexico Beach, and they had told people this is big and it's coming, but 50% of the people did not evacuate, leading to some real tragedy. So the issue is that identifying risk needs to occur at the appropriate time, and that's not when screening should happen. That needs to be well in advance of that. So in our paper, we proposed at least a decade earlier, 35 instead of 35 instead of 45, that we begin to message more broadly about colorectal cancer and the importance of identifying your risk, getting your screening on time, and then if you're normal risk, making a decision amongst the various choices that are available to you.
That has kind of a high-tech sound to it. Is that accurate?
Which part?
The whole notion of lead time messaging, is it sort of high-tech driven?
No, I think it's super low-tech driven. I think the answer and why it's a big ugly is none of our healthcare systems, even though we collect the data, really ever present that back to the patient or the physician as an actionable piece. Physicians many times fill out family history so they can get through their electronic health visit because it's required, but are they really applying what they entered into the record against a recommendation guideline? And I think that's one of the missing connections. So I think there's a high-tech component that can help physicians do a better job, but I think it also has to be at the intersection between what patients know so they can be self-empowered, and also what physicians need to understand in terms of their capacity to prevent disease. Because going on offense in colon cancer means finding polyps and taking them out to prevent cancer, or finding those early cancers that are asymptomatic that can be treated with surgery alone, or sometimes removed just with endoscopy. So it's really more than that. It really even goes back further into lifestyles, not smoking, good diets, lots of fruits and vegetables, avoiding sedentary behavior. Those are all contributors to colorectal cancer, and that's further upstream in terms of going on offense. But I think we can't go all that way, because those are harder to change. Changing people's behavior is not as difficult as changing their behavior to get a cancer screening.
Now, here's a 2-part question. Legislatively, there are things you have done within the Commonwealth of Kentucky to advance the fight against cancer. First of all, and it might be a long list, but if you could mention the things at the top of the list and things that can be done not only in Kentucky, but elsewhere, what are some of those things that you've attempted, ways in which you've attempted to advance the ball legislatively?
Well, we got started on this in 2008 because the American Cancer Society used to grade states whether or not their insurance policies covered colon cancer screening. That's how far back we're going now. And Kentucky did not have any type of a mandate. So when we initially started, we wanted insurance companies in 2008 to cover colon cancer screening. We were inspired by some of the groups in New York as well as Colorado to actually create a program for the uninsured. And we did that, but we were unfunded in 2008 because that was the Great Depression, or recession, if you will. We later were able to get funding to develop that program for the uninsured and underinsured. So I think that was the greatest thing, was getting people access to screening that was going to be covered as a no out-of-pocket service. Something that we were supportive of but didn't really do was the Medicaid expansion in 2014, which really opened up almost 600,000 people in Kentucky to healthcare services. Then we attacked, after this, in about 2014 or 15, we became aware that what was happening when people went in for a colonoscopy that was supposed to be no out-of-pocket, free screening service from insurance, that if you went in to get a screening colonoscopy and they found a polyp, that those codes were being changed. So instead of having a free screening test, you now had a multi-hundred or multi-thousand-dollar bill that you were responsible for. I liken it to doing a safe driver's course and your insurance rate goes up. I mean, who wants that? And that was fought at the national level in Washington for many years unsuccessfully. And, you know, it was characterized as a loophole, but I personally like loopholes, right? I like things that help me advance things. I really think it was a bait and switch, which no one likes a bait and switch. So we were able to get that removed and at the same time provide an important conduit for the future of screening. As we do more and more non-invasive tests for normal individuals, so stool testing with FIT, stool DNA, commonly known as Cologuard, people see it on television, FIT testing, fecal immunohistochemistry, but we're also going to have urine tests, we're going to have blood tests, we're going to have a variety of these less invasive tests. But to follow a positive non-invasive test up with a colonoscopy, previously put your colonoscopy into a diagnostic category, not a screening category. So you might get a $10 test that's positive, but your colonoscopy was going to cost you $2,000. So that in no way helps to close the loop. So we got rid of that bait and switch legislation in Kentucky in 2016. And we were one of the first states. There's several other states that have since gone on. Illinois, Washington State, and Maine have all enacted legislation now to do this. So this will be a state level battle because at the federal level, we're not going to be able to get too much done. The last thing is we were able in 2019 to normalize coverage for genetic testing as a preventative service. Since the ACA went into place, testing for breast and ovarian cancer for people who had a family history was covered as a no out-of-pocket screening cost, but genetic testing for colorectal cancers, pancreatic cancers, prostates was not. And so it was a really hassle to get this paid for when you identified folks. We eliminated that in 2019. So now if you meet NCCN, which is the National Comprehensive Cancer Network, the guideline organization for genetics, your genetic testing coverage is no out-of-pocket in the state of Kentucky. Because we think the future is going to be led by protein, DNA, artificial intelligence, other things. We can't believe that we're fighting the battle with just stool testing or colonoscopy. That's like saying, how are we going to get to the moon? A car or a horse and buggy?
Our guest is Dr. Whitney F. Jones of Louisville, Kentucky. He's the founder of the Colon Cancer Prevention Project, also based in Louisville, and we're going to talk about the project in just a bit. But Dr. Jones, I realize you're not familiar with the legislative battles that are taking place in all 50 states, but I do know that you get outside of the Commonwealth of Kentucky, so you see what's going on in other places. If there's any way you could put a single fine point on this, what would you say is the biggest obstacle to getting from point A to point B so that people can be screened not only for colon cancer, but other types of cancer in a cost-effective way that is not going to act as a deterrent?
I think the biggest part that's come on in the last 10 years has been the Affordable Care Act and then the Medicaid expansions. You can't underestimate the importance of having these screening tests be no out of pocket and no cost to people as a way of lowering barriers. Then you're primarily dealing with the behavioral issues about making them aware that it's important, again, that it can prevent cancer as well as save lives from it. It's not just a way to diagnose you as a, oh, you got cancer, now you're not going to make it. So I think those are the single most important things that really cover the nation. But I think what's critical at the state level is having a state-based organization that is dedicated towards lowering barriers within that state, including the loophole, as we spoke about, the bait and switch, and advancing other causes. I think there's a real catalytic effect towards having a nonprofit organization that's not a state funded or a state employed organization that can really work on a problem 24/7, 365, raise their own money, not be sort of tethered, if you will, by all the things that happen through convention and large organizations that are federally funded.
Now, it sounds like a lot of the things you just mentioned are things that are very much part and parcel of your organization, the Colon Cancer Prevention Project. If you would, Doctor, tell us more about the genesis of the project, which you have to some degree, the genesis of the Prevention Project, what it's doing now, and any other areas it hopes to conquer in the future.
Right. And by the way, call me Bruce. That Dr. Whitney F. Jones is going to get me nervous here. I'm a no tie guy anymore. So,
okay, Whitney, Whitney, it is.
Yeah. So in terms of the project, it's really, I would call a catalytic organization that seeks to accelerate change and accelerate implementation of operations. There are a lot of great academicians that I work with across the state and the nation who are doing an amazing job at studying things, but we really focus on this spate of organization. It has to be important. So we're in colorectal cancer. That's the second leading cause of cancer death. Kentucky leads the nation still in cancer mortality from colorectal. Number two, there have to be guidelines already in place. And then third, those guidelines aren't being followed significantly. So we've carved out a really great space for ourselves because everything we work on has data-driven, evidence-based information behind it, but just isn't getting operationalized. So our organization, I'd say we went through 3 phases. The first phase was there's a lot of low-hanging fruit. We can do everything. So we did television shows. We did walks. We did pamphlets and brochures. We've handed almost 2 million brochures out across Kentucky and surrounding counties about colorectal cancer. We put stickers on the back of long-haul truckers. One of the companies here allowed us to put colon cancer messaging on the back. Pegasus Trucking, if any of your guys are interested in taking a peek at that. I'd say the second phase was really what I would call our legislative phase, where we really began to interact with our state legislature. A lot of great people there, both in the executive branch and the legislative branch, as well as really we haven't done anything with the judicial branch, knock on wood. But those guys have been great, and without their help and leadership at the government level, none of the things that we wanted to do or thought needed to be done were there. And then finally, I think now we're really in the consolidation phase where we're really looking towards bringing in these ideas that we've put forward. And again, we are the most improved state in the nation for colorectal cancer screening in the last 20 years, I think in large part due to the great partnerships we've developed across the state, but also really being an innovator in terms of new technology, the DNA pieces we've talked about, the new types of testing. We're looking at new ways to reach people in their early ages when they're at higher risk through different informatics, digital marketing, getting to people on their cell phones where they live rather than relying on this happenstance of a person who needs it, happening to see a doctor who happens to listen to them and orders that test. That's too random for us. So we're really reaching out to engage both patients as well as providers. We work a lot with healthcare systems as well in order to close the loop on that. So I think our real focus in the future is going to be, how do we use the tools of the native digital people to communicate with them about their risk so that they may go on offense for cancer. Because if the person doesn't go, the system has a hard time pulling them.
Now, you mentioned some of the more new media vehicles to get the word out. Are you as far along as you would like to be with that, or are there still new frontiers to conquer?
There are new frontiers to conquer, but we're on the cusp of doing some pilot programs. One of the bigger issues that faces Kentucky is that our rate of early age onset colon cancer, defined as people under age 50, is the highest in the nation. And in our Appalachian regions, which are Eastern Kentucky, and again, 17 states have Appalachian regions in them throughout the East Coast, our rates of colorectal cancer under age 50 are even higher. So I really think that in Kentucky, colon cancer starts a decade earlier. So we believe our messaging has to start a decade earlier, not to get screened always, but to understand your risk and to understand when you should be screened, as well as most people who have under age 50 colon cancer don't have a family history. They don't have a genetic history. It is a sporadic issue. We don't understand what that's caused by yet, but it's probably something in the environment, something we're eating. It might have been something they were exposed to during early life and birth experiences even. So we don't really understand that, but we know we have to communicate to them that risk. And if you have rectal bleeding, abdominal pain, unexplained changes in your bowel habits, unexplained anemia, weight loss that you can't explain, from your 20 until you're 45, you need to get into a doctor and demand, not just go and be fluffy, but demand an evaluation to rule out colon cancer, because it is absolutely affecting a whole new age group. In fact, let me give you one statistic. If you're born in 1990 versus born around 1970 or 50, your rates of colon cancer are 200% increased. That's right, 200. And your rates of rectal cancer are 400% increased compared to someone born decades earlier. So we have got to have a new strategy, because we're facing a new disease.
The Colon Cancer Prevention Project. There might be somebody, Whitney, who would like to get hold of the project, or more specifically, they might be wanting to get hold of you. Do you have a couple of web addresses you can share with us, so if somebody wanted to reach out, they could do so?
Absolutely. Our website is kickingbutt.org. But certainly if you Google up Colon Cancer Prevention Project, it will take you in there. And if you reach our executive director, Amanda Smart, who's a master's in public health, doing a great job, I might add, she can connect you to my email and through us. So we'd love to hear from anybody who's interested in reformulating the project for the world. We have lots of tools that we ship all around the world, actually, in terms of products. We have documentaries. We just released one on public broadcasting system called Preventing a Killer that just came out this year, that's really getting rave reviews. So I'd ask people to come to our website, look under our education tab, and if you want to contact us, we would absolutely like to work with you.
All right, Whitney, one final thing we want to talk about, and I may be asking you to repeat something you've mentioned earlier, but if you will, pretend that you have a private audience with somebody right now, somebody who's watching or listening, somebody who thinks that they might be a candidate for colon cancer. If there's any one overarching thing that you would like to, any point you'd like to drive home with them, what would that be?
You do not have to die from colon cancer. You can prevent colon cancer through screening. And if you happen to have colon cancer, finding it at that earliest stage gives you the best chances of beating it. Our chemotherapy is better, our radiation therapy is better, our surgery is better. So this is not a single prevention, but the way to manage colon cancer is through prevention. Don't be afraid of it. Talk to your doctor. If colonoscopy is not your choice, there's lots of other options. But if you have symptoms that you're concerned about, as we've discussed, go to your physician now, demand an evaluation. If they say no, get another opinion.
Wonderful. Our guest has been Dr. Whitney Jones of Louisville, Kentucky, and the Louisville-based Colon Cancer Prevention Project. Dr. Jones, Whitney, thank you very much for your time. A lot of fantastic information here, and now it's up to the viewer to go and act on it. Again, thanks so much for being with us.
Bruce, thank you and your team for allowing me to share our work in Kentucky and be available to fight and improve our work.
And that's it for this segment of Cancer Interviews. Remember, TEAM, together, everybody achieves more. Until next time, we'll see you on down the road.
Thanks for joining us today. For more information, please visit us online at cancerinterviews.com. We appreciate you tuning in, and we'll see you back here again next time on the Cancer Interviews Podcast.